Good morning, everyone, and welcome to our Conversations on Care, our Facebook talk show bringing together our service providers, our clients, and caregivers to help families better understand and cope with aging parents with chronic care needs. My name is Julie Collada. I'm the founder and president of Open Arms Solutions, and Open Arms is a home care agency serving the Chicagoland area, focused on inspired home care solutions for seniors who are dealing with chronic conditions such as dementia, Parkinson's, and other movement disorders. It's our mission to help our families through this journey and to know that their loved one is living their best life possible. If you find these dialogues helpful, please give us a like and share so that we can reach more people who need this. We've been doing this program for over a year now, and our audience is growing, which is just terrific. And thanks so much for sharing this with your contacts. If you have a question or topic you'd like to learn more about, please write them in the comments below. We pay attention to that. We love ideas about new topics that would be important to you. With me today is Ken Russell, who's the Area Vice President of Business Development for Elara Caring. And our topic today is, what is the difference between home health care and home care? That is the $1 million question. And, this is the old saying, if I had a nickel for every time someone asked me the difference between home health care and home care, I'd be a wealthy woman. It's such a confusing topic. Those terms are used interchangeably. And I'm really so glad that we're talking about this today. And I'm thrilled, Ken, that you're joining us. Tell us a little bit about your background, if you would. It's always nice to start these conversations and let people know a little bit about who's in the conversation. Tell us about your background and how did you arrive to be the Area Vice President of Elara Caring?
Sure thing. Well, first off, Julie, thank you, and thank Open Arms for having me here today. I'm thrilled and pleased to be here. Just a little background. I'm currently the Area Vice President of Business Development for Elara Caring Home Health, and we also do hospice services as well. I've been with the company for 5 years. I've been in home health care, however, for about 18 years. I've been in the healthcare field, working, whether it's sales or sales management for home infusion, also home DME, and of course, home skilled care.
And what is home infusion for those folks that are?
Sure. Home infusion would be for a patient that would need infusion therapy, whether it's antibiotic, it's TPN, it's really pharmacy therapies such as those that normally a patient would receive in a skilled setting, such as a rehab center or hospital. They can actually receive home infusion services in the home. So the company I worked for, which was at the time Quorum Healthcare, they were able to, it's basically a larger pharmacy, able to mix and ship drugs directly to patients' homes. And then we would work with skilled home health in terms of the nursing component to get the patient set up on their home infusion therapy.
Sure. That's great.
Yep. And the other, as mentioned, I've been in home health care for about 15 years. And coming out of college, I really wanted to get in the healthcare field. I kind of saw back in those days, this is back in kind of when pharma was real big, and a lot of newbies just out of college heard about the kind of grand and kind of glamorous position as being, whether it's a pharmaceutical representative or what have you. But I looked more at home health care, and I just saw at the time that may be a little more fulfilling in terms of taking care of patients for a longer term, and having them under our care to get the outcomes that they would need being under skilled home health, and of course infusion and DME, which I should just mention is durable medical equipment. That would be patients that would need a home walker, Hoyer, for example, a Hoyer lift. So basically, between myself working at Quorum Home Infusion, Elara Caring, skilled nursing, in hospice, and as well as DME. That's kind of the three larger pieces to home health care as a whole. So the goal is to, of course, take care of patients in the home setting. That's where they want to be. That's where actually you get the better derived outcomes for the patients. So it's been a very fulfilling career in home health care.
That's great. My story is a little bit different. I never intended in college to be running a home care company. So my journey was a little bit different based on personal experience.
Well, I think
Grateful that I got here.
Yeah,
What?
I think we both picked some pretty good careers because, as mentioned, the need for home health and home health care is growing more than ever. And I think over the last couple of years has really
Yeah.
emphasized that tenfold.
Oh my gosh. The people want to stay in their home.
Yep.
Right. And there's
Absolutely.
been more and more emphasis on how important that is. And so, yeah, I agree with you. We're in an amazing space. And I think too, my unexpected um, benefit of being in the space was just very fortunate to have it be so fulfilling personally.
Mm-hmm.
It's certainly both of you and I are responsible for building our respective organizations. Um, but we get to wake up every day, as challenging as it is, and as challenging as it has become during COVID, more challenging during COVID. We know how much of a difference our team makes and we
Mm-hmm.
make in people's lives, and that's an amazing feeling. And I'm sure you feel that way too.
Absolutely.
So let's get to the basic topic of today. Let's start there, which is what is the difference between home health care and home care? And by the way, before we start to talk about that, I remember when I first entered this industry. Well, I remember when I first needed to get help for my mom in 2006. I was so confused, and I found that some of the physicians that they weren't able to help guide me with what the difference was, because there is a lot, even in healthcare, there's confusion on that topic, what the difference is. So, and certainly many people at home get confused about it. So what is the difference, Ken? Help enlighten us. Start the conversation. What's the difference between home health care and home care?
Yeah, and there's been really confusion on both lines of services, for quite a long time. And but I think the key word that really separates in terms of the services that we provide under skilled home health and personal care services, private duties such as open arms, would be skilled. So skilled care would be when a patient is in need of somebody clinical, whether it's a licensed registered nurse, whether it's a licensed physical therapist. The patient would need care in the home setting, but needs somebody with specialized training and background, and they're licensed, quite frankly. And that really is a separation. So the caregivers that would treat a patient under skilled home health would all be licensed clinicians and have experience in home health. And some of the, I kind of drill down in terms of some of the types of services we provide under skilled home health to add a little more detail and color to it. So, for example, I mentioned skilled nursing, and that would either be a registered nurse or a LPN. We also do home physical therapy. And of course, physical therapy is a type of treatment that helps restore and improve the functionality of the body. Occupational therapy. This therapy also really helps empower patients and to improve their functions of their daily living. We also have a speech therapy program at Elara Caring, and that really is this particular therapy works to prevent, treat, and assess patients with any speech or swallowing disorders. So it's really skilled care that if you ever had a loved one in a hospital or a rehab center, and they're in there for 24/7, of course, that's why they're inpatient, they're receiving skilled nursing, physical therapy, occupational therapy. So it's the next shift of the level of care and the location of care from a patient going from a hospital, from a rehab to the home setting. In terms of our regulations, how often we're seeing patients, it's deemed intermittent. So we cannot see a patient daily, and that's a CMS Medicare regulation as well as insurance as well. So normally we're in to see patients 2 to 4 times per week. And that's really working with all lines of services, therapy and nursing. But skilled is that key word. It's just kind of the place of care moving from acute, hospital, subacute, rehab to the home setting, receiving skilled care.
Yeah, thank you for that. That's really helpful. And I think that it's a great explanation. The part of it that I think about a little bit is that I really do think that caregivers are very skilled. They're just not licensed by the state like a physical therapist, occupational therapist, speech therapist, nurse. That's it's they have more of a clinical and licensed background for those needs. And so that's a very, very good explanation. So when, we'll get phone calls here, and who typically, well, let's back up for a second. You made reference to Medicare. So, and you talked about home health care. In home care, and part of the confusion is those people use those terms interchangeably.
Mhm.
People use, I've heard people talk about what we do as home health care. We have, so that just adds to the confusion. There's that term called private duty, which is when you talk to people in the world about, well, what in goodness is private duty? Well, it was the way of helping people differentiate between home health care, which is the payor is Medicare for people over 65 years old,
Mm-hmm.
and private insurance. That's who
Yes.
pays for home health care in what you just described, Ken. Right?
Absolutely. Yep. It's Medicare and managed care. Yep.
Managed care, correct. And so who pays for home care? We'll talk about that a little bit. What is home care? And why was it called private duty? Well, home care is not paid. Home care, and we'll define that. So home care is not paid for by Medicare. And home care, which is what Open Arms is focused on, is helping people stay home with activities of daily living. And also they're called incidental activities of daily living. So it's things like helping people and assisting, you think about if someone can stay at home, and obviously if they need nursing services, if they need physical therapy, and they need occupational therapy, that doesn't necessarily mean they need home care too. But what we're finding more and more is that paired together, home care, which supports making sure, one of the reasons people, unfortunately, especially people over 65, really probably more people over 75, get admitted to the hospital in the first place is because of a fall in the home. So home care, private duty home care provides assistance in helping people ambulate, which is a fancy word for walk around and move safely at home, and monitor someone to see if they're unsteady on their feet. They might need some assistance from a caregiver to make sure that they can move around their home safely. They might need a caregiver and home care for helping in bathing. A lot of falls happen in the bathroom, and people might not be strong enough when they're at home for whatever reason. It might be that they've been discharged from the hospital yet at home, or a skilled facility, rehab facility, but they're still not strong enough to be able to bathe themselves safely or dress themselves safely or easily and comfortably. They might need assistance with eating and meal preparation. They might need assistance with housekeeping and those kinds of things. And all of those different things fall under the area of home care, what's called home care, where a caregiver or a CNA can provide that care. It's also helping people drive, and transportation services and companionship services. Everything that's kind of not physical therapy, occupational therapy, nursing services, but it's still needed to keep someone safely and comfortably in their home is home care.
And I would just add to that, Julie, and you detailed that perfectly. But truly, how we see it is home care in terms of what Open Arms can offer. It's really customized care. And I wouldn't deem what we do in skilled home health as customized. So we put together a plan of care for a patient. We have set goals, and we're not expecting to see them usually longer than 30 to 45 days, sometimes longer, sometimes shorter. But in terms of, Open Arms and the services you provide, you can truly customize what the patient's needs and their care to their scenario or what have you, or situation. Yep.
That's a great way to put it. I appreciate that. That's a really good way to think about it. And when, we're going to talk a little bit about how people hear about home health care, right? And how people hear about home care. We each go in and we do some kind of an assessment, whether it's home health care, we assess what the patient needs. In home care, we assess what the patient needs. And then we both create a very specific care plan. And yeah, Ken, I appreciate that definition. I think that, for home care, it's very customized around what is the gap between what and we call them clients, not patients, the client and the family, what kind of support can be provided at home and what kind of support is needed that's not there. And then home care kind of fills in that gap.
Absolutely.
So that's a really good way of describing it. What are some of the triggers that cause need for home health care?
Sure. Well, just to kind of, in terms of insurance and Medicare covering patients for skilled care, a patient would have to be deemed, and this is something from CMS Medicare, homebound, meaning that to qualify for services to be covered by Medicare, the patient would have to really be in a scenario where it's a taxing effort, and that's their words, a taxing efforts to leave their home. So a patient can receive skilled home health services covered at 100% by Medicare and insurance if it's a taxing effort to leave their home. It doesn't mean they can't leave their home. They can actually drive to their church, they can drive to their physician, they can drive to the hospital, but it's a taxing effort to do so. They can drive to their grocery store. If they live in a rural area, A patient getting in their car, having to go to a local market, the only one for 40 miles, Medicare will still allow home health coverage, even though the patient is leaving their home, because if they're not able to go out and get their groceries, obviously that's a problem. So, but homebound, it's kind of a gray area. And quite frankly, Medicare, it's almost by intent. They look at each patient in terms of their scenario, where they live or what have you, what resources they have. But when looking at skilled home health and some triggers, when one would identify whether it's a physician, a hospital, a loved one, for a patient that would qualify or would need home skilled care, would be a recent ER visit, recent surgery, patient has poor gait or poor balance, they're at a fall risk, problem swallowing, a new medication as well, teaching training. We all know the importance of medication reconciliation and the patients really understanding their new medication, which many times they're not. All they're getting is what's on their bottle or what have you. We do a teaching training, our nurses do, in terms of that with patients. A new diagnosis, if you have a new patient that was recently diagnosed as a diabetic, we'll come in and do teaching training, and of course looking at the dietary piece and some other pieces as well. And so really there's a large number of exact triggers, but those would probably be our top 6 or 7. And primarily it really is a recent inpatient stay at a hospital, ER or subacute center, or they're ready for that next level of care in the home setting. They've kind of graduated to be able to be home, still needs skilled services, but don't have to be inpatient.
Great explanation. So many people then where many people get a recommendation on what home health care company to use starts at the hospital. Is that correct? Is that where you get most people hear about what you do?
Yes. So great question. So, my liaison team that goes out and calls on hospitals or physicians, they're looking for referrals. There's about 550 skilled home health agencies in metropolitan Chicago. It's actually one of the highest volume numbers of home health in the U.S. Florida would be number one, of course. But it's changed over the last 15 years in home health. The hospitals and the rehabs and the physicians, just because they're graded on rehospitalizations and metrics such as that, they've really weaned down the skilled agencies they will use. So you've got to have a phenomenal readmission rate. You've got to have some clinical programs. You've got to really be able to make sure the patient's at home and meets their goals. And if you do, the hospitals tend to kind of narrow it down in which agencies they will use to provide the best care and outcomes. And all that's tracked by Medicare.
Yeah. And that, in my opinion, and I know you share this, that's been a great change that's happened with Medicare and the way they incentivize companies that are paid by Medicare. It's really, there's so much focus on quality and keeping people home and safe. And that's how your quality measures are.
Yeah. Elara Caring, we're blessed enough to have a partnership with Northwestern Hospital and other hospitals, and we have to meet with them quarterly, and they go over their readmission metrics and what have you. And that never happened 10, 15 years ago with the hospitals. They just get them out the door. But now that they're held to a higher standard, of course, by Medicare and insurance, that filters down to the home health agencies, which is how it should be.
Yeah, I agree with you. So how quickly do services typically begin? What does that journey look like? Can you give us an example of when
Sure.
you take on a new patient, what that looks like?
So normally when we do receive a referral, we do have to have a physician's order or a nurse practitioner. That changed actually under COVID. That's now allowable. So we would need an order from a physician. They have to detail the patient's diagnosis. We would acquire paperwork such as a patient's H&P, history and physical, of course, their insurance information, their medication list, just so when a nurse walks in the patient's home, they've got a really good idea what the issue is to put together the care plan for the patient. But normally when we do receive referrals, it's with a physician order and segments and parts of the patient's EMR, their chart.
Their medical record, their
Yep.
electronic medical record.
Yep.
Gotcha. How quickly when someone's discharged then from the hospital, how quickly will they see someone?
Sure. So once we received a signed order from a physician, whether it's a physician who's rounding over at the hospital or a hospitalist, or even directly from a physician's practice or their clinic or their office, we normally start service within 24 to 48 hours. That's kind of been the standard. I have to say, and not just at Elara Caring, the first, I'd say, 6 months of the COVID epidemic, there was a lot of confusion and what have you. Some nurses actually walked away from the nursing field, not just in home health, but also in other acute settings. So that was delayed a little bit in terms of patients getting started, but normally 24 to 48 hours. That's a metric in which we're held to.
Yeah.
Have a start of care.
So very quickly, which is obviously very key.
Yep. That will help reduce the rehospitalization chance.
Yeah, for sure. That's so essential.
Yep.
So in terms of, well, I know you have some, oh, there's a viewer question. So hang on a second. My goodness, we're almost out of time. So the question is, how does one incorporate their primary care physician when receiving home health? Oh, that's a great question.
Yeah, great question. There's a couple of moving parts to it. So, for example, if you have a senior that lives in a assisted living, and the director of nursing who's responsible, to make sure of the wellness of the residents, we could get a referral from the director of nursing at that building itself, the assisted living building. We then would follow up with the PCP, the primary care physician, to get the actual order. Or sometimes it comes directly from the hospital. They really are down pat in terms of having a signed order, the discharge plans when a patient is going home. So we will help with that. We will work on getting a signed order from a physician if there isn't one. So we have patients' families calling all the time saying, "I heard you took care of my grandmother. I've got an uncle. His gait, he's not able to walk to where we're confident he's not going to be a fall risk." Then we will call the physician and go over our feedback. And normally they'll ask to see that patient. They'll go out and see the patient or set up an appointment, and then we'll get an order for the patient, in that case, for physical therapy, for example.
Okay, that sounds great. And will you circle around with the primary care physician if the referral comes from a different physician, right? And it's not the primary care. Would you get the primary care physician involved?
Yes, absolutely. Great question, because when a patient does leave a hospital or subacute setting, at that point, that hospitalist or what have you, they're not going to follow the patient. We'll get an order, we can start services, but then we have to follow up with the PCP to make sure they're going to follow the patient, and we send corresponding orders or updates to that PCP. It kind of switches over.
Great. There's so many acronyms in healthcare, but there's so many acronyms in any industry. But I think healthcare has a jump on out of. So primary care physician is PCP, and then there's the hospitalist, right? And that's kind of a relatively newer phenomena in healthcare, where the hospitals actually employ physicians to follow patients in the hospital. So lots of different healthcare professionals that are part of the puzzle often. Which are important for people to understand, because it can get very confusing.
Absolutely.
So I know that Elara Caring has some specialty programs. Can you talk about those?
Sure. Yeah. One thing that does absolutely set us apart, that's a big benefit to working for Elara Caring, is we have a number of clinical specialized programs that, quite frankly, a lot of the other home cares do not. One example, we've got a behavioral health program, and that's a growing need, especially boy, it doubled the number of referrals over COVID. That would be a behavioral health and psych nurse that has over 10 years working with behavioral health patients and psych patients, whether it's patient depression, anxiety, loss of a spouse, bipolar, behaviors caused by Alzheimer's. We also have a program for Parkinson's patients. It's known as the Lee Silverman Voice Training Program, LSVT, Big and Loud. And that's really working with a therapist, a PT, a physical therapist, working with the patient on their movements as Parkinson's patients tend to kind of stiffen over time. They don't have their movements decrease pretty quickly as their diagnosis progresses. But our PT keeps them active with movements to the point where they're not experiencing that stiffness. In addition, the loud piece of Big and Loud would be working with our speech therapist. So I have an uncle who has Parkinson's, and every year when I see him, his speech is more muffled, and he tends not to talk much, and his volume of his volume of his speech gets lower every year, where it's almost to a whisper, and he may not even realize it. And a lot of patients, quite frankly, they kind of shut down as their speech is muffled, and they're a little more self-conscious of it. So they're not talking much because people are saying, "I can't hear you," or what have you, and they feel bad about it, and so they're not social, and so it progresses. So our speech therapist will work with that patient on vocal exercises. We'll shout out this word, and it's consistent, working to increase the loudness of one's speech. And it's just it's more of obviously an in-depth type of therapy, but it brings back not just the volume of the patient and them being able to speak louder and more confidently, but it's that word confidently. And so all of a sudden there's a huge change in their social world. They're actually able to communicate with loved ones and talk to them one-on-one and be confident in doing so. And it kind of brings back that relationship with the patient and their family.
Yeah, that's so important. That is a great program. And, one of the things that, and you and I have talked about this together, we have a specialty in Parkinson's, and we also have a specialty in dementia care. And being able to provide the right home health care partner that can deliver. And you had mentioned that, you have a specialty in behavioral health, and often, people as they progress in their dementia, and there's all sorts of different kinds of dementia that have different, they're called behaviors. It's when, the dementia causes different difficult interactions with different people because of the demencia. So it
absolutely.
Could be.
And I know we don't have too much time, but a really quick story. So sure. A great example of our behavioral health program. So we have a behavioral health nurse who's been seeing patients, especially the geriatric population, for about 15 years. And she worked with a family. They had a small little home, and their loved one had just a front door and a back door. And as his Alzheimer's progressed, he would go on walks, which he'd been doing for years, but they were worried he was getting lost. His neighbors were saying, your dad's been walking to this park for a while. He seems a little lost. Well, we actually received a referral for this patient. Our behavioral health nurse went in, and as the Alzheimer's was progressing, she actually went with the family to Home Depot, and she purchased 2 large black rubber mats. And she placed them in from the front door and the back door. And as a patient's Alzheimer's progresses, when they're walking, they see that black mat more as a black hole, and automatically it repels them to move away from that particular area. So that patient was no longer walking out the front or back door when family was not around or what have you. And that was a big relief to the family. So little things like that really helps.
Oh, that's a great example.
Yep.
And, we are out of time. I knew this would go fast. I knew there was so much information to talk about with folks, but I will tell you that I know that, the topic was what's the difference between home health care and home care. I hope we helped solve some of that today. I think we did. I think the thing that's also important that you can, and your team and Open Arms team recognizes that there's never been more of a spotlight on home care and how important it is with everything that's happened in the last, 20 months with the pandemic. And I think it's exciting to think about how when we team up together, in particular, when home health care and home care partner together, how effective we can be at keeping people safe, keeping them at home, keeping them living their best life possible. And I know that motivates both your organization and my organization.
Truly the best of both worlds when patients can have both services in their home. It's best for the patient, and it makes a lot of sense. And that's the direction. And that's where ultimately that's where patients want to be.
Yeah.
That's
where we want our families to be, right?
Yeah.
Ken, thank you so much.
No,
I so enjoyed talking with you.
My pleasure. Absolutely. Thank everyone for joining today.
Yeah. All right. Take good care.